A term which is misunderstood, unfortunately, is Alzheimer's disease. Unfortunately, it has been used for two completely different things, and that confuses people. It was described by Alzheimer himself back in 1906 as a pathology that was associated with dementia. So it's the pathology, which is the amyloid presence in the brain, which is the phospho-tau, which is causes what's called neurofibrillary tangles. These are neurons that have begun to die, and they've changed their shape. And of course, the synapse loss is striking in that disease. And so that's a pathology. So that pathology that we call Alzheimer's is present for all four of the phases. You can be pre-symptomatic and have those plaques and tangles. You can be at the SCI stage. You can be at the MCI stage. You can be at the dementia stage. Unfortunately, people often use Alzheimer's disease just to refer to that fourth and final phase. So they'll say, oh, well, you got MCI, but you don't have Alzheimer's yet. Well, sure you do. You have Alzheimer's pathology present, which you've had for years because SCI typically lasts about 10 years. So I think it's important that we understand that Alzheimer's is a pathology. So then those four phases, as I mentioned, the final one is dementia. And dementia can be due to Alzheimer's. It can be due to dozens of other things. It can be due, for example, to Lewy body disease, frontotemporal dementia, vascular dementia, progressive supranuclear palsy, what's called late, which is something that's been described just a few years ago, which is typically people in their 80s and 90s. It is essentially a late form of dementia, but is a non-Alzheimer's. The reason we think about Alzheimer's as the, quote, cause of dementia, it is the majority. It's by far the most common cause. And it is about 60% of all people who develop dementia will have Alzheimer's dementia. But Lewy body, very common. 1 million Americans with Lewy body disease. Many people with vascular dementia as well. Frontotemporal dementia is less common, but all of these are causes of dementia or diseases associated with dementia. And of course, it's turning out that for all of these, what they have in common is essentially that they are a network insufficiency. So you have remarkable networks in your brain that have been evolutionarily chosen to give you great performance. And as an example, in the neuroplasticity network, we as humans can store more than 2,000 home computers. So you can imagine 2,000 home computers lined up, and everything that those things can store, that's what you can do in your remarkable brain. So you've got tremendous neuroplasticity, but that is pushing the evolutionary engine. You're pushing the envelope here to get that much storage. And so what happens is through evolution, we select for performance over durability. So we are at risk because of that lack of durability. And so now we understand more and more what's now driving these things over the edge. And with Alzheimer's, as I mentioned, the common things are anything that's creating that inflammation that drives you from just having some amyloid to actually having some cognitive compromise. Anything that is causing toxicity, and the big three, of course, are inorganics like air pollution and mercury, organics like microplastics and anesthetic agents, and things like TCE, various things that are organic toxins, toluene, benzene, things like that, formaldehyde. And then the third one is the biotoxins. And these are typically toxins produced by mold species, things like that, trichothecenes, ochratoxin A, things like that. So you have to actually look to see what's going on there, what's driving the process. Those are the big ones. And then the more modest three are reduction in neurotrophic activity, so trophic support, hormones, nutrients, and things like nerve growth factor and BDNF and things like that. And then neurotransmitters, things like acetylcholine. You need those neurotransmitters for the communication, of course. And then the third one being stress. And I should add that the big three, toxicity, inflammation, and energetics is the third one. So you need the blood flow, you need the oxygenation, you need the mitochondrial support to keep those synapses and to be able to learn new things and maintain those connections. So interestingly, when you have problems, when you don't have that support, or when you have too much drag from various pathogens, toxins, etc., your brain does a great job of essentially pulling back and saying, okay, I can work with a little less. I'll still be able to do and remember the things that I've learned. But you're clearly compromising things. You're going to have trouble learning new things, which is exactly what you see. That's telling you, that's the canary in the mine. That's telling you, okay, you need to improve. You need to find out what's driving this. You may have sleep apnea, for example, very common cause of cognitive decline. You may have some metabolic syndrome, very common cause of cognitive decline. You may have a change in your oral microbiome, things like that. You can find them, you can address them, and you can get better. And we see it all the time with people who are improving their cognition. It's really, really striking.
For somebody who is, say, relatively young, they feel like they're relatively healthy, but they're noticing cognitive decline, and they want to get in there and find out what is causing it. You've just named a whole bunch of different inputs that would likely need to be explored. What's the best way to go through this systematically? Starting with what would be most likely, I would assume, to detect what could be causing that.
Yeah, this is a really crucial point. Just as what's happened in the last 30 years, what have we heard about? We've heard about childhood obesity. We've heard about childhood diabetes, type 2 diabetes, which was supposed to be adult onset. We see that more and more. We've heard about things like leptin resistance. We've heard about things like brain fog in young people. So actually, next Monday, I'm headed to UCLA to talk to the undergraduates, which I do once every year. Professor Rachel Lee has a course on biotechnology. And the whole point of this is, why should a college student care about Alzheimer's? And the answer is because it used to be thought of as old-timers' disease. But now we know that this is something you can actually see, and this has been documented, changes in the teens and early 20s. Now, you don't get a diagnosis typically until much, much later. But interestingly, the epidemiologists have published just in the last couple of years that the most year-over-year growth in terms of percentage has actually been in the 30-somethings and 40-somethings. So even though when I was training, way, way back in the 1980s, we never saw anybody. It was typically a disease of your 60s, 70s, 80s, 90s. Now, one of the most common things we see is people in their early 50s who actually have progressed all the way to dementia. So they've gone through those earlier phases. So the point is that this is very much relevant for just the way we're living day to day. It's very much associated with cognitive health. And so, in fact, I wrote a book about this called The Ageless Brain. The whole idea being, don't wait until you start having cognitive decline to get on this. We recommend anyone, as I mentioned earlier, 35 or over. But look, if you're 25 and you're having some brain fog, there's a reason for this. And one of the things we are seeing, especially related to COVID and long COVID, is that people will often have brain fog that continues. And again, identifying the causes and addressing them will make people better. As you know, a lot of people have had chronic fatigue as part of long COVID. But of course, the most commonly cited symptom in long COVID is brain fog. So it is very common. And again, it's telling you don't have the support there. That network is not getting enough support for the demand. So, usually when you're young, you got plenty of supply. You don't have too much demand because you don't have a lot of toxicity. You don't have a lot of inflammation. But when you get COVID, and especially if you get long COVID, now you've got more on the inflammation side. And if you've got these microthrombi often, so now you're reducing the supply. And so now you do get to a point where you are developing brain fog, even though you may be 25, for example. So it actually is important for young people as well as old people like myself to be aware of these things and to recognize that, hey, the armamentarium is huge. It's not what it was even 10 years ago. We can look at these things, we can understand what's driving this, and of course, there are all sorts of better understandings about how to support that, how to look at whether you've got sleep apnea. Creatine is a big thing right now. People are recognizing, yes, this does give you an energetic boost. This does often help your thinking as well as building muscles and things like that. And there are hundreds like this. We're seeing what happens with photobiomodulation. So red light therapy as an example. What frequencies are working best? What wavelengths are working best on the light? And what frequency of light delivery? And people are typically using gamma frequency to get best outcomes there. There's a big push now to plasmapheresis, to detox people. There are new columns coming out for this as well. So more and more, there's an understanding of what's causing the problem and what we can do about it. So again, it brings us back to nobody should get to the point of full-on dementia.
Let's talk to that 35-year-old right now who is feeling good, feeling like their brain is healthy, but they want to get on this like you're recommending, get the proper testing done. What is the bare minimum but foundational tests at that age they would want to have done?
Yeah, great point. So when we originally set up the testing for people who have cognitive decline, which we called RECODE, reversal of cognitive decline. So you have a testing set, and then you have a protocol that addresses those things. A number of people came up and said, well, yeah, what about the 30-somethings and the 40-somethings who have no symptoms at all, are doing great, but we just want to prevent? So we set up what's called PRECODE, prevention of cognitive decline. And this is a little bit more limited test. So this is why I recommend if anyone is at high risk, I would go ahead straight to RECODE and skip the PRECODE. If, for example, people who know that multiple family members have passed away from Alzheimer's disease, that sort of thing. But in general, yes. So what you want to know is, it goes back to the things that we know drive the problem. So you want to have tests that show any sort of inflammation, things like HSCRP. These are simple things to do, but unfortunately, many doctors are not checking them, and they should. The good news is you can get this, you can now get this over the counter. There's a big push, of course, to more direct-to-consumer testing. And so you can find out these things. For example, you can go get a free cognitive assessment at mycqtest.com. See where you stand. You can also get, if you want, you can get the blood test that I mentioned. I just got my own p-tau 217 checked and GFAP and NFL. I'll do it again in a couple of years. And you can do that through Get a Brain Scan. It's called Brain Scan, but it's just a blood test, getabrainscan.com. So for people who want to prevent, as you said, the 35-year-old who want to prevent cognitive decline, get checked out. You want to know what's going on with inflammation. You want to know what's going on with your methylation, because that's an important part of your detox. So you want to know your homocysteine, as an example. You want to know what's happening with your lipid status. Do you have high triglycerides already, which so many people do? What is your triglyceride to HDL ratio? Helpful to know your Lp(a) and your ApoB as well. Those are all important to tell you, are your vessels doing well? Are you supporting things? If you're having any issues with sleep, and of course, I recognize the book, The Anxious Generation, all about the fact that there's so much anxiety in young people. Okay, if you're having any issues with sleep, that is important. So I check my own sleep every night. You have 4 targets for your sleep every night. You want to know that you have at least 7 hours of sleep, and you can do this with a wearable, an Oura Ring, or a Fitbit, Garmin, Apple Watch, whatever you like. But find out where you stand. Track. This is all part of really productive biohacking. Find out, do you have at least 7 hours of sleep at night? Do you have at least 90 minutes of REM? Do you have at least 60 minutes of deep sleep? And then, do you have an oxygen saturation of at least 94%? For people who are developing some sleep apnea, we'll see them in the 80s, and we'll even see them into the 70s, where they have a dramatic desaturations of the oxygen. And that's a problem because, for one thing, they'll kick in their adrenaline. So now they have issues with hypertension. They'll wake up. They'll impact their own sleeping. It's a real problem. So all of these things are really important. So you want to know your sleep status. And then you want to know, as I mentioned, some of these metabolic parameters. And then you want to know your p-tau217. And actually, I was just meeting with a group yesterday, and these were young people, and saying, okay, who here knows their p-tau217? And nobody knew their p-tau217. Well, they're all going to know it pretty soon. So it is a good thing for all of us to know. So all of these things are critical. And of course, having your fasting insulin is really important to know, because before you get full-on diabetes, you get pre-diabetes. And at that point, your hemoglobin A1C is going up. And once it hits 5.7, you have pre-diabetes. But before that, fasting insulin, so that's pre-diabetes, literally insulin resistance. And so seeing if your fasting insulin is drifting up, and we see it all the time at 10, 15, 20, I've seen it over 30, you really want to see it more in the 3 to 6 range, not up there at 10, 15, 20, or 30. If it's high, what it means is you have insulin resistance. And you know what's interesting? Amyloid and insulin are surprisingly related. So it really, again, tells you there are critical pieces here that are all working together. So as your fasting insulin goes up, as you become insulin resistant, so insulin degrading enzyme, which is supposed to be degrading the insulin, guess what else it also degrades? Amyloid. So if you've got that high insulin all the time, your amyloid is going to start to drift up because your IDE is degrading your amyloid and is degrading your insulin and not being able to degrade your amyloid. So these do go hand in hand. And by the way, the amyloid also interacts directly with the insulin receptor and inhibits the signaling through the insulin receptor. So these things are literally part of the same overall mechanistic system.
Earlier, we talked about the person that is asymptomatic at this point, younger, getting testing done. You went over the comprehensive tests to have done to just assess and keep tabs on things. What would you add to that for the person who is, say, a little bit older, starting to have memory issues, cognitive decline? What additional tests would you stack on that?
Yeah, great point. So, as I mentioned earlier, there are these 4 phases. And it's interesting, almost all Alzheimer research and treatment has been in these final 2 stages. Not picking up people at that pre-symptomatic stage and really focused on them, and not picking up people at that SCI stage, subjective cognitive impairment. But those are the easiest to treat. Virtually 100%, as I mentioned earlier, of those people respond beautifully. So if we could simply change the conversation from the last 2 phases to the first 2 phases, we could make it so that dementia is a rare condition. However, when you're now clearly having symptoms, or if you are in, as I mentioned earlier, family that's got genetics and you're concerned about that, a common one is ApoE4 associated Alzheimer's disease. So if you look at the population as a whole, about 3/4 of the population has no ApoE4. And there are about 100 different genes that are associated with Alzheimer's risk. But the common one, and the one that is striking, is ApoE4. So I checked myself, for example, I'm an ApoE3/3, which is the most common. About 3/4 of the population has that. Our risk for cognitive decline in our lifetime is about 9%. If you have a single copy, which is 75 million Americans. And unfortunately, most don't know it. And we should all know our ApoE status. You can get it from any genetic testing. You can get it from your doctor. You can get it also online with the one that I mentioned earlier. You can get it, you go to mycqtest.com, any of those things. Then your chance is now up to 30%. And if you look at all Alzheimer patients, 2/3 of them are ApoE4 positive, even though it's only a quarter of the population. So it's clearly an important risk factor. Then if you look at people who have 2 copies of ApoE4, and that's 7 million Americans, most of whom don't know it, their risk is about 90%. Most likely they will develop Alzheimer's, but they don't have to. So this is why it's so important everybody find out early, get on active early prevention. This is, of course, what came up recently with Chris Hemsworth, who found out that he is ApoE44. Okay, don't worry about it. Get on active prevention and you should do very well. Now, for people who say, well, I'm at high risk or I'm beginning to have some symptoms, you brought up a great point. What are the things you now want to look at? Okay, so there is a whole set of things. And it basically, as you begin to find these out, you want to do a little bit more in one area or another. So you want to find out, has there been any toxic exposure? And so you want to know, what is your mercury, your inorganic and your organic mercury, for example? Do you have heavy metal toxicity? What is your lead status, your cadmium status, your arsenic status? That's easy to do. Secondly, you want to know, what is your organics? What about your formaldehyde? What about, people are now measuring microplastics. No question, unfortunately, microplastics have turned out to be associated with a number of problems, including cognitive decline. And when you look in the brain of people, in fact, you do see a concentration in the brain of these microplastics, more than the kidney, more than the liver, and it is associated with cognitive decline. It's not yet clear whether it's causal or a result or both, essentially a loop, but it is definitely associated with it. And interestingly, even if you look at people who have carotid plaques, who have reduced blood flow to the brain from the carotid, those people do more poorly if the plaque that's in the carotid happens to include microplastics. So even though it's still the same size plaque, if there are plastics there, they seem to do more poorly. So this is a huge issue. So you want to know your organic toxins. The third part of the toxins, again, as I mentioned, you want to know your mycotoxins. And now, Dr. Richie Shoemaker has done such a beautiful job over the years in defining CIRS, chronic inflammatory response syndrome. He's argued that these tests are really not yet ready for prime time. We haven't done enough validation of these. And I think he has a good point. At the same time, if we don't identify and address these buildup, these increases that we can sometimes undergo in these various toxins, we see that people don't get as much better. They do better if you find toxins and you address them. They do better. And there are multiple ways to go after that, from the PK protocol that Dr. Patricia Kane put together, plasmapheresis, these new columns I mentioned, such as MTX100. There are numerous ways to do that. So you want to know your toxins in detail. What else you want to know is, you want to make sure to know your oral microbiome. So you can do that with MyPeriopath, for example, oral DNA sorts of testing. There are others as well. Do you have a lot of P. gingivalis? Do you have a lot of T. denticola, Prevotella intermedia, all these things? And the good news, again, very treatable. Everything we look at now, there are things to address it. So the armamentarium that we have to use for cognition, for optimizing cognition and for preventing decline, is huge, and it's growing. There are supplements. There are things like the photobiomodulation I mentioned, the EWOT, HBOT. All these things are available. Finding the right thing at the right time for the right person with the right test, that's the trick. That's the difference between a really good practitioner and a not so good practitioner, to look to see. And by the way, we saw in the trials huge differences. We had 6 sites. 4 of the sites got spectacular results. 2 of the sites got virtually no results. So it does make a difference to have one of the sites that did not get good results, relegated the patients to an untrained physician, really didn't understand this protocol well enough, and did not get good results. No surprise, which was really unfortunate. So you want to know these toxins. You want to know then various pathogens. So you want to know, where do you stand? For example, do you have high response to HSV1, HSV2, herpes simplex? That is associated with cognitive decline. Do you have tick-borne illness? Dr. Neil Nathan has done such a beautiful job over the years at showing how important Borrelia, Bartonella, Babesia, Ehrlichia, Anaplasma, all these tick-borne organisms are in various syndromes, including brain fog and cognitive decline. And so this is a huge issue. Knowing those and addressing those, so important. So those are all key. Of course, 100 years ago, it was all about, do you have chronic syphilis? Is that the thing? And so we've kind of, penicillin came in, syphilis, tertiary syphilis is uncommon now. But what's happened is we have the equivalent. We have the analogy to what was being looked at 100 years ago. For example, the Borrelia, Lyme disease, this is the same sort of spirochete. You see similar brain changes as you did in tertiary syphilis. So that, again, identifying these and addressing these to get best outcomes is so important. Then you're right, you want to go a little further on the genetics. And whether you like to do it, you can do it with 3x4 genetics. You can do it with IntelliX DNA. There are multiple companies that can do this and look to see whether you have specifics for cognitive decline. So you want your genetics. And now, of course, epigenetics is coming into view. And we worked in the trial, we worked with a group called True Diagnostic that does epigenetics. And we can actually see, very interestingly, specific changes. And this is in the preprint that we talked about earlier. And interestingly, we saw changes in neuroplasticity. We saw some reduction in brain age, and so-called omic age. And then we saw some marked changes in things associated with neuroplasticity and inflammation. So you can begin to see these changes as you are addressing things optimally. So these are also things you want to know. And then we talked earlier about the standards, methylation, inflammation, things like that. You want to go a little deeper, and for example, you want to look at things like either TGF-beta1 or MMP9, because these reflect this SIRS that Dr. Shoemaker described. These are reflecting chronic inflammation, often associated with these various toxins and organisms. So now you're beginning to get a much better picture. As I said earlier, you can look and see what's going on in your brain with things like your p-tau. Well, then you can see what's causing it with all these various biochemical pathways that we're talking about. Now this gives us a very detailed look at what is driving your decline. Okay, now you can pick out, these are the things that we need to optimize to get back that optimal cognition and sustain it. And I should say, we were the first to show over 10 years of sustained cognitive improvement in people who came in with cognitive decline. That was published last year.
Since you made it to the end of this clip, I know you're going to love the full episode. Click here to watch. I'll see you over there.
About 15% of our population dies of Alzheimer's. So about 45 million of the currently living Americans will die of Alzheimer's. We can reduce that number dramatically.